Hey everyone, and welcome to RUBIN'S Mind Lab, where we break down the latest research into what it really means. Ever wondered why some medical experiences leave you feeling unheard or even harmed, while others lead to genuine healing? Well, today we're diving into some fascinating psychology research that sheds light on how racism can show up in the doctor's office, and more importantly, what we can do about it. This research asks a really big question: how can interactions within medical spaces lead to real healing outside of those spaces? And how can we make sure everyone involved in care is on the same page to help people get better? It suggests that health is really about whether a person's power is being undermined or supported. Think about that. Your health is linked to your power. So, how does racism get mixed into our visits to the doctor or hospital? The research dives into this by looking at people's personal stories. They collected amazing qualitative data from 563 Black Americans about their medical visits that felt racially charged. And wow, the experiences shared are eye-opening and frankly heartbreaking. One of the big themes is what they call reinforced biological views of race. This is where doctors or medical staff might make assumptions based on someone's race about their health issues. For example, a patient might say, "I was automatically assumed to be able to jump and run fast during fitness testing." Or, "I know the stereotype that all Blacks have hypertension." Another person noted hypertension diabetes is always affecting Blacks. It's like they're told their race is the reason for their illness, rather than looking at the whole picture, including lifestyle, genetics, and environmental factors. It is not about acknowledging genetic predispositions, but solidifying harmful stereotypes. One person even said, "I am aware of the health risks of my race," highlighting how ingrained these assumptions can become. And another shared an experience where a nurse couldn't find their veins and said, "It was a bad day to be Black," which is a really stark example of how race can be invoked, even by mistake, in a medical setting. Then there is racism among physicians. This is where overt racism or deeply ingrained bias affects how care is delivered. People reported doctors who seemed hesitant to touch them. Like one patient who said, "I encountered a doctor who did not want to touch me for physical exams." I spoke with other Black patients and found they were having the same experience. Others experienced assumptions about their healthcare needs, such as an OB-GYN assuming that I wanted invasive birth control for 10 years. Some felt dismissed, with one person lamenting, "My doctor in the past, I feel disregarded what I was saying." And then there is the direct discrimination, like, "I was just recently dropped by a physician because of my race." These aren't just isolated incidents, they're patterns that undermine trust. Another significant area is how weight and size play into medical bias. The research highlights how often people feel their doctors solely attribute all their health issues to their weight without deeper investigation. One person shared, "I feel my doctors don't provide me proper medical care because they feel every health issue I have can be solved by losing some weight." Another recounted the dermatologist who, instead of addressing acne, became obsessed with my weight and talked about nothing else. His whole demeanor was one of disgust. This is really damaging. The paper also brings up the point that for Black women, carrying extra weight can come with undue stigma, leading to automatic assumptions. There is also a critical point made about the BMI index potentially not accounting for different ethnicities' natural body types, noting that African American women tend to be more shapely and curvy with hips and thighs naturally. This shows how a seemingly objective measure can perpetuate bias. Stereotyping is another powerful theme. People reported being treated differently based on socioeconomic status and race. One person said, "You just get treated different if you're Black and on Medicaid." Others face age and gender stereotypes, like one woman who described being thought of as an uneducated single mom, because she is a young Black woman with 2 kids and most of the time my husband is not around. These stereotypes can deeply affect how a patient is perceived and treated. All of these experiences contribute to mistrust in the medical system. When patients feel like they're being experimented on or talked down to, as one person put it, "Doctors using me for a guinea pig, prescribing meds I didn't need without doing tests, talking down to me as if they thought I was not smart." It erodes their willingness to seek or trust medical advice. There is also a concerning mention of epilepsy patients being presumed to have substance abuse issues, and specialists lacking the sensitivity to relate to minority groups. And tragically, one person shared, "I've been put on birth control that can cause me a higher possibility to have breast cancer, and my doctors knew of my mother and aunts having breast cancer, and still prescribed it, showing a severe disregard for family history and potential risks." So, if these are the problems, what should equitable care systems actually produce? The research outlines 4 key things. First, validation acknowledging that what is happening outside the body, in our social world, has found its way into our health. Second, affirmation focusing on what a patient can do, like saying, "Your race is not a death sentence," rather than dwelling on past issues. Third, enrichment providing transformative knowledge, for example, explaining that family history is not the same as genetics. And fourth, a comfortable environment creating natural and timely exchanges between patients and providers. Now, the big question, how do we change physician attitudes? The research points to inclusive interventions using the trans-theoretical model of behavior change. This model helps understand that people are at different stages of readiness to change. For those already taking action, it suggests supporting them with helping relationships, creating anti-racist action, oriented events instead of exclusive gatherings, and using reinforcement management rewarding good behavior and punishing bad. For those more contemplative, the approach involves self-reevaluation, making anti-racism part of a physician's identity. Social liberation recognizing environments that encourage anti-racist action, and environmental reevaluation understanding the impact of these actions. Essentially, it's about meeting people where they are and guiding them through stages of change. The paper includes an interesting quote about DI training not always being effective. It highlights a perspective that too many required trainings cover the same ground without real impact. The sentiment is that major issues surrounding DI are systemic, and forcing day workers to sit down for endless DI sessions is similar to BP coining the idea of an individual's carbon footprint. It is a convenient way to shift the onus onto the individual. This points to a perception that some well-intentioned efforts can feel performative and overlook the systemic nature of the problem, placing the burden solely on individuals who are already aware and trying to make a difference. Ultimately, the research emphasizes that reducing racial health disparities means taking racism out of the equation in how we structure our medical systems and having absolutely zero tolerance for shameless attitudes about racism. So, how do we assess if changes are working? The paper suggests using bystander intervention theory. This theory asks if a provider notices a microaggression, interprets it as needing intervention, assumes responsibility, decides how to help, and then actually intervenes. Applied to healthcare, it means asking, did the provider see the subtle racism? Did they understand it needed addressing? Did they step in? This framework helps evaluate the proactive role medical professionals can play. In closing, the researchers stress that tailoring solutions for racism in medical spaces requires understanding where people are in their readiness for change to promote inclusion. It's about centering the patient's micro-experiences, staying humble, mindful of what we don't know, and involving everyone. Recognizing that patients also have variable readiness. It's a journey of reciprocal learning and action. This research is incredibly important because it moves beyond abstract concepts of racism and grounds the discussion in the lived experiences of patients. The qualitative data is powerful, showing us the real, human impact of racial microaggressions in healthcare. It gives us a roadmap for what equitable care looks like: validation, affirmation, enrichment, and comfort. The insights into changing physician attitudes using behavior change models are practical and acknowledge that one size doesn't fit all. And the bystander intervention theory offers a concrete way to think about accountability. However, there are always things to consider. While the qualitative data is rich, it primarily focuses on the experiences of Black Americans. Future research could explore similar experiences across a wider range of racial and ethnic groups to ensure a more comprehensive understanding. Also, the discussion on DII training highlights a valid critique that needs to be addressed in how we implement these crucial initiatives, focusing more on systemic change rather than just individual awareness. The implications of this research are huge. If we can implement these principles, we can move towards medical spaces that don't just treat illness, but actively promote well-being and power for all patients. It is about building a system where people feel seen, heard, and respected, leading to better health outcomes, not just within the clinic walls, but in their everyday lives. It is a call to action for all of us, whether we're patients or providers, to be part of creating that more equitable future. That is it for this episode of RUBIN'S Mind Lab. What are your thoughts on these findings? Have you experienced anything like this in your medical visits? Let us know in the comments below. If you found this explanation helpful, please give us a like and subscribe for more breakdowns of fascinating science. Thanks for watching, and we'll see you next time.